Safe space.
Safe space.
Safe space.
Safe space.
Safe space.
A place where I can be free.
Somewhere I feel like I won't be judged.
My bedroom.
A place without fear.
Hi, and welcome to Safe Space, a podcast for open, honest, and deeply human conversations about mental well-being. I'm your host, Paulyne Wanyonyi, and I'm really glad you're here today. We've reached our final episode in this series, and so far we've talked about how suicide shows up in our lives in silence, in struggle, and in the things we don't always say out loud. Today, we're shifting gears a bit. We want to talk about support. Specifically, what kind of support actually helps when someone is thinking about suicide, has survived an attempt, or is grieving someone they've lost to suicide. If we're being honest, getting mental health care in Kenya is still really hard for most people. Therapy can cost anywhere from 2,000 Kenyan shillings to over 9,000 Kenyan shillings per session. And in just 2024, there were up to 17 counties without any psychiatrist. That means many people dealing with suicidal thoughts, especially in rural or underserved areas, can go without the care they urgently need. But we also want to explore some of the solutions out there and spotlight a few positives in terms of available resources. There are people and programs doing powerful work to fill the gaps. One example is the Friendship Bench. It's a grassroots project that trains trusted community members, usually older women, to offer talk therapy on benches in clinics and public spaces. It began in Zimbabwe and now exists in parts of Kenya too. It's low cost, it's familiar, and it works. Here at home, we're also seeing youth-led groups, online platforms, and mobile apps where people can check in anonymously or find someone who'll just listen. These are especially powerful for young people living with suicidal thoughts who may not feel safe turning to family or formal systems. But to truly offer support that's accessible and exists in a holistic ecosystem, we need to ask important questions like, how can schools train teachers to recognize warning signs and respond with care, not punishment? What are some ways families can learn to talk about suicide without shame? And can communities create real, safe spaces where people can speak openly and find support without fear or judgment? In today's episode, we speak to our guests who are working on the ground about what's working, what's still missing, and what gives them hope when it comes to supporting people affected by suicide. We also want to gently remind you that we've put together a list of a few resources in the show notes of every episode, and that you can access them as you listen or after. Today we are joined by Dr. Zaccheus Were and Tom. Let's get to the episode. So welcome to the show, Tom and Dr. Were. It's very lovely to have you here to have this conversation. Before we begin, may I ask that each of you introduces yourself? I'll start with you, Tom.
Thank you so much for having me. My name is Tom. I am the founder of Shamiri. Shamiri is a Kiswahili word that means to thrive or to flourish. And our mission is to make young people thrive by having access to cost-effective mental health interventions.
Okay, great. Thank you. And Dr. Were, how about you?
Yeah, thank you for having me here. I think it's a privilege to be here. I am a family physician. I work in Bungoma, work for the county referral, and also do private practice, just taking care of the people of all ages, all sexes, and ensuring that they are accessible to health in all aspects. Actually, I go and love taking care of people on a mantra of wholeness, just looking at all the aspects of their lives. That's what I like doing.
Okay. Again, thank you both for being here. So we've been doing a series on suicide, and this is actually the final interview episode that we are doing, and we wanted to wrap it up on a note of hope and looking at what is already being done on the ground. And I think you are both doing fantastic work on the ground, which is why we chose to have both of you here today. So to begin, when you think about suicide in Kenya today, what feels most urgent and what feels most possible? Tom, I'll begin with you.
Yeah, so what feels most urgent, in my opinion, and that also ties to some extent to what I think feels most possible, is just around the policy ecosystem that we have around suicide, and just to ground it on the work that we do across high schools, for example. Currently, suicidal attempts is still illegal. And so if you are working within a school and you're working with a client who has either attempted suicide or has suicidal ideation, there are a lot of barriers to their care, which are just put in place by the policy regimen. In that, more concretely, for example, in the school setting, if it's a boarding school, the school doesn't want someone to commit suicide on their watch. You also have to do some, like reporting in theory, because of like the legislation that we have. And so it's just bringing, a lot of like barriers to this. And whereas the High Court has, in theory, ruled that that should be decriminalized, at least, from the perspective of the law of the land, that is still the position. And there still doesn't exist policy framework to help folks who are working on the front line of providing care to think about this. So a lot of like suicidal attempts are actually underreported, not very well, kind of like prevented or like dealt with, just because we do like lack there's legal policy framework that then enables organizations, be it organizations like Shamiri or even like hospitals like the one that Dr. Were is working on, to be more proactive about dealing with these things. I do think that this also presents the most opportunity from a possibility perspective, because it's really easy in theory to put in place, like the policy guidance on how to do this. And generally, the Ministry of Health has over the last few years like really advanced mental health policy in Kenya, with strangely the rare exception of like dealing with suicide. And so I think it's a pretty easy win that could happen, and that could actually unlock a lot of opportunities for folks who are working on the front line to be more effective in dealing with this issue.
Okay, Dr. Were, do you have anything to add to that?
Yeah, so in addition with that, I think with the increasing rates of suicide, they say like 4 cases of persons die daily, and as you've said, that's an reporting because of the stigma and all the things associated with that. I think what, for me, in addition to that, is key is how you train our people on resilience and coping mechanisms, in the sense of life will continue to be crazy. The rates of unemployment is going up. The commitment to policy is a bit shaky. The environment, climatic, geopolitics is getting very unstable around the world, not only in Kenya. So people, how we can have the people have a coping capability. And I like the effort that you guys are doing and what many of us are trying to do. Having a system of mentoring people, teaching people, advocacy into the ability to have coping mechanisms that will help them at an individual level, and the fact that people are accepting and like the government is now a bit decriminalizing these aspects of suicide, then it means people are accepting to be taught and to be guided into these things. And if we can have more effort like this, I think we'll go a long way. And that's what most of the times I do. I try to teach even my own staff about how to be resilient in times that are coming crises. I do a lot of human development to just teach people about crises and the increases of that, and how you survive, how you stand your ground as we go by. And I'm sure as we continue like this, there's a lot that can be done, a lot of positive in the little steps of teaching and advocacy.
Okay.
Yeah.
So, for the both of you, the work you're doing is quite non-traditional, right? Both for you, Tom, and you, Dr. Zaccheus. And both of you are part of providing solutions in different contexts. So, what problems exactly were you trying to solve when you started the work that you are starting? Tom, maybe I'll start with you. When you began Shamiri, what were you trying to solve? What issue had you seen?
Well, I think that's a complicated question, but I'll try to answer it, simply. So I think for me there were a few different threads that we were trying to weave together when founding Shamiri. So the first one was just like universally, not just in Kenya or Africa, but around the world. No one has really figured out how to effectively prevent and treat mental health problems. And even, for example, with the case of suicide, we still don't have a full understanding of the mechanisms that actually move someone from suicidal ideation to suicidal attempt, right? Right, and so more broadly, universally, we just still haven't really figured out the experience of mental health, how to properly diagnose it and treat it and prevent it, etc. But then, kind of more concretely, in our context, we have this convergence of a few issues. So one is assuming that, and it's good to give these assumptions, assuming that the current ways that we are thinking about and treating mental health problems, including suicide, work. So assuming that that is the case, we don't have enough infrastructure to do that from human resources perspective, not enough psychiatrists, psychologists, etc. As Dr. Were mentioned, we don't have enough. There's a lot of stigma around mental health. In my opinion, actually, the stigma makes sense. It makes sense that people stigmatize mental health, mostly just because of the history of psychiatry, in Kenya. And also, of course, mostly our understanding of mental health was mostly defined in the West and, copy-pasted, for us here. And where stigma doesn't exist and where you have providers, care is very expensive and often, doesn't work. So the question for us is, could we build an organization that could directly try to solve for these problems while at the same time trying to innovate to arrive at an African-based understanding of what mental health, really means. And so how we've gone about doing that is by doing a few things. So one is borrowing from work in primary health around task sharing and task shifting, the idea that you can train and mobilize non-professionals to be effective in helping with mental health. And actually, if you think about the Kenyan context, most mental health problems are dealt with by non-professionals. So
That's
be it
true.
your family members, be it your pastor or your imam or your school teacher or someone in the community, etc. And so we built this tiered care model where at the base of it, we train high school graduates to, go back into schools and lead peer groups. And then we also work with folks who have some background in mental health. So they either have a bachelor's or they've been doing some social work or they've done some community health, work as well. And then eventually we also triage to the few psychologists and psychiatrists, that we have. So the idea is you match people with care depending on, kind of the needs that they have, right? So someone who, for example, is suicidal, will need to see a psychiatrist, but part of the help they may need might be social support. In which case they may benefit from being part of like a group session, in addition, to that, right? So that's the core of our model. But also at the same time, we are actively doing research and asking ourselves, if we were to define, quote unquote, what we call depression in this context, how does it look like? How does it manifest? What are effective, therapies and interventions for this, which makes sense, within our context? And how do we do this in a way that leverages the infrastructure that we have, the power of community, and also really emphasizes on making things accessible, community-driven, etc. Because otherwise, most people who have the need don't really get to access care.
That is, it's a brilliant model, honestly. And, you've been able to address a very urgent issue. Just like you said, both of you have said, there's a lot of lack of resources. We don't have enough psychiatrists. We don't have enough mental health providers. So to be able to look at that problem and find an immediate and accessible solution that people can actually go to is very important and impressive. So that's amazing work. And Dr. Were, for you are a medical doctor, and I know that you have your own clinic and you actually go and see patients sometimes out in the village in their home, people who actually cannot access these resources where they are. Could you tell us a little bit more about your work and what problems were you trying to solve, and how did you get involved in mental health as well?
Yeah, so I think from the time I was in high school, I got interested in people's issues, and most of the times I would sit with people and listen to their problems, and I have a lot of I would listen a lot to them, and moved by that, I went to medical school, finished, and then it was, I think, in my postgraduate that the interest even grew. When I finished, I was posted to Bungoma County Referral, and I would sit with a patient for 1 hour, 2 hours. And sometimes it will run into the night. The issue is my system trying to solve their complex matrix of problems. And I got very interested in that, and I would say God really helped me, because as one day I was running a clinic, and there's one of the landlords I used to help to collect rent for her buildings wanted to see me, so she came around and shouted, and the patients were actually waiting on the queue, "Dr. Were, you need your clinic." And the patient shouted back, "Na huwa tunamwambia na asikii." And those words grew in me over the week. That was on a Monday in a public hospital. By the time I was getting on Friday, the mantra of it was so loud. They decided to go check into that, because she came back and told me that I have a place for you. So when I went, I found a place, a dusty place, and that's where the issue started. But as a vision has been, from the time I was young, I registered a hospital name when I was in 4th year in campus. So this was like an ignition of that. And the driving force was actually how to give people a holistic approach to things. That's why I'm a generalist, because people have social issues, people have economic issues, people have psychological, mental issues, people have spiritual needs, and that's why I will take long with a patient. So so that's how we came up with what we have. So I try as much as possible to build a system that is very holistic. My staff, I trained them to look at life, not just as doctors or nurses or what. I look at a person as a whole. When a person presents themselves, it's an opportunity to see them in their family, to see them in their school, to see them in their community, because it's like everybody who comes from a certain environment, and that way you are able to tell what's disturbing this child in school, and what is disturbing this lady in their marriage. And in that way, I might not be a trained psychologist, but in just knowing the people's problems and knowing that people are like an object that is whole, you get to know the deficits and how to sort that. So in the little resources and time that I have, we build a hub for wholeness. That's the slogan for connection hospitals, like a hub for wholeness. And when a patient, I always tell even the cleaner, whoever is there who interacts with patients, is just be looking at the holistic, the whole approach. And that's why I think, for me, mental health is key, because that's the most overlooked part. Because most people, when a client or a patient comes to hospital, they deal with their physical aspects, but they don't deal with their mental, because it's deep-seated. It's very, most of the times they present like normal other patients. They'll come with headache or fatigue or something, and they will be brought to you when those issues are not taken care of. So we're trying to build a system where an awareness of that is on the forefront. Because mental health, you have to have a very high index of suspicion, otherwise you miss it out. And I guess it should be for something that cuts across, whether it's a pastor leading the people, whether it's an imam, whether it's a teacher leading children, or whatever. It cuts across, whether you're married and you're looking at your wife and your children. Some of those aspects, if you see life as a whole, you will always know that this person is not growing well in this area, or my child is not doing well in this area, and you're able to pick if there are early signs of mental health or any other inadequacies there are. Like, you find children growing up and you find maybe their efforts of development in the economic and financial areas are wanting. That could be a source of depression later, that could end up into suicide. So everyone, parents, teachers, psychologists, psychiatrists, everyone is not exempt. So I am trying to build that awareness in the small connection hospitals, or so to say.
Yeah.
Yeah.
Okay, the work you also do is very impressive, and I think a lot of, okay, maybe I'm biased, but I think there's a lot of doctors we have these days who maybe don't really listen to a patient. And sometimes I have an aunt who's a doctor who actually tells me you learn a lot from a patient when you actually listen to them, beyond just trying to note down symptoms, just listening to what they're saying. Because sometimes, just like you said, it may not be anything really medical that is wrong with them. Sometimes it's other problems that are maybe presenting in a medical lens, but that's not what it is. So the holistic approach is very important. So Tom, back to you. In previous episodes, we've discussed how a huge problem is that most Kenyans will not resonate to the research and the models that are available because they're created with a very Western lens, which you've touched on briefly. And like you said also, the resources are also scarce. So how did you adapt evidence-based models to make them culturally resonant in Kenyan schools?
So the key is not adaptation. I think the key is creation.
Okay.
Right? Because adaptation, I think, in my opinion, just means you're trying to repackage, what exists there, maybe with like local language, etc. But the fundamental underlying thing is still the same, right? And so basically, and this is an ongoing process, and I don't think we've figured it out yet. But basically, we've been trying to ask ourselves questions in a few different buckets. So the first bucket is around how we define what a disorder is. And if you basically broadly think about most mental health problems, what happened is at some point we were like certain type of human behaviors, if they manifest in this way, they are a disorder, right? And so the question we've asked ourselves is, if we were to do that from scratch, how does that look like? And how does that also overlap with what our current understanding is from the Western model? So to give an example of a study we did in 2019 in Migori County, basically we were asking ourselves if we were to ethnographically from the ground up build a classification for something which resembled what we currently think about as depression in the Luo, what will that look like? And what we found was interesting. So what we found was about 60 to 70% of the presentation overlapped with what we currently, understand. So things around, trouble sleeping or, sleeping too much, things around like appetite, motivation, etc. But what was interesting was how they overlapped, right? So to give two examples, one with suicide and the second with sleep. So with sleep, currently, if you are to go to a psychiatrist, they will just ask you, are you having trouble sleeping or are you sleeping too much? If you ask that question, at least in this community that we're working with, you will end up like under reporting cases because actually the way that they were describing it is more about rolling in bed. So at night, are you rolling from one side to the other side rather than, or did you sleep too much or didn't you not, kind of like sleep too much? So that's an example of where like words, kind of like really matter. But then the other example with suicide is one where intent is different. But once again, just saying this is from this community. So the way we think about suicide, at least from the Western model, is very internalized and self-directed, so I want to harm myself, etc. But what we realized is, especially for adults and especially for male adults, it's the way it presents, it's a little bit externalized. So it's more from the perspective that, I am failing my family doesn't, kind of like need to be there. And that's why sometimes in these cases, you will see cases of, someone killed their family and then committed, kind of like suicide, after that, right? And so this is an example where the presentation of that just completely, manifests, differently. Anyway, so that talk is a little bit ongoing, but that's the first bucket, just to give an example of, kind of thinking about that. The second bucket is around like treatment and thinking about interventions. And a big mistake we have done, and that's why my personal hashtag is sometimes decolonize the mind, is we have assumed that the Western model is the gold standard for treating mental health problems, and we've abandoned a lot of our traditional methods. And we work with this professor who maybe you should bring to the podcast at some time, called Professor Ndete, who was one of the people who inspired me to join mental health. But he gave this really interesting talk where he was like, I was a psychiatrist and I realized I was sharing 90% of my patients with a traditional healer. So I asked myself, okay, let me go to this traditional healer and, kind of like see, what are they doing? And he was pretty impressed to the point that he made the claim that actually some of the psychiatric medications were stolen from traditional healers, where they went and figured out what the active ingredients were and then turned them into, like a pill. But anyway, the point of this being that when thinking about treatment, there are a lot of different things that we can tap into. And so for us, because we work with young people, one of the things we've realized is for most young people, very brief targeted interventions that are focused less on reducing or treating depression, for example, and to your point about thinking about people holistically, but more on improving their overall functioning and giving them, kind of skills to just like go through life can be really effective. So especially in high school, just to give two examples. The first is this idea of sense of belonging. So most of our public high schools are boarding schools. You have people from all over a county or the country come to one school. It's a new community, and one of the big questions that young people have is, okay, how do I belong here? Am I going to be accepted in this, place? Of course, a lot of dynamics around, class and economics and also tribe and ethnicity, etc. And so if you have just like sense of belonging interventions that make young people, feel that, they deserve to be where they are, they belong, that can actually be both preventative and therapeutic for mental health, and also like a classical one around this idea of a growth mindset. So if I'm having an issue with my parent, it doesn't necessarily mean that that is something which is wrong with me, but there's an opportunity to grow and become better at like problem solving and cultivating, different types of relationships. So just to like summarize, so thinking about how we define disorders and thinking about what constitutes, effective intervention. We've been able to show, that with, kind of the simple interventions, with kind of tapping into the powers of groups and community, working with just people, high school graduates, people have like just a bachelor's or a diploma or a community health, background, they can also be as effective in delivering, these interventions. And so actually our broader call, and that's why it's exciting to have this conversation with Dr. Were, is we also need to extend this model writ large to think about, we need to work with the clergy, for example, and the clergy are also quite effective in doing, kind of what they do, but they can be also a good referral pathway and a good downstream referral pathway for people who maybe don't need to, kind of see a psychiatrist, right? And community health workers and even like traditional healers, as part of like reimagining and rethinking what care looks like in our context.
Okay. I like that you said creation and not adaptation. That's very important. And I think that's a very, very important point. And just like you said, we do need to decolonize a lot of our models, because we take what the West gives us and then we come and copy paste, and then we wonder why it's not working, right? Because it doesn't make sense to us and to our culture and to our communities. And just like you said, we've spoken about in previous episodes, language, because sometimes we are trying to get information out of somebody in a manner that does not resonate to them. So, if you're asking somebody like, do you have any loss of interest? They can't relate to that, right? But then if you break it down in a manner that makes sense, usually you go to the shamba every day. Have you been to the shamba? They tell you, no, I've not been for 2 weeks, right? That makes more sense to them. Yeah, so that's a very important point. Dr. Were, I'd also like to hear from you. How are you making things culturally resonant to people in Bungoma?
Yeah, I think that question is very key, in the sense of most definitions around mental health and most even medical diagnoses and all that, most of the underlying principles cut across. But the interventions really depend on the different environments, especially for mental health, because the things people are exposed to, or the environment in which they are grown, or the era in which they are. Like, if today you talked to teenagers, there are things that bother them or the things that influence their development that is likely to be very different from how I was raised. Because the environment I was raised in is more enduring. Like, I will stay alone in town without my parents when I was class 4 or 5. Today, that might be very different. So the principles remain the same of definitions of presentations and what, but the interventions depend on all those aspects: the cultures of the people, the belief system, the era in which people are born. Like you will find most people who are aged, they have beliefs around suicide and depression and anxiety that the current generation will not have. And that's why I don't blanket everything into one. It doesn't lie in one big canopy. The principles remain the same. So the 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 truest technology should be that when a client comes in or a patient comes in, you read them as they come. Read them what influences what they are. You look at a person based on the environment in which they are in. So teenagers, adults, you look at the environment and then you know exactly where they are, their issues, and what can exacerbate these issues of mental health, depression into suicide, all that. And then you tailor the solution based on that. But the principles are interesting because I'm sure the West, they spend a lot of money and all that to do research and all that. And looking at our situation, we might not have all that. But the flexibility of tailoring these solutions to what we have. Because I'm a strong believer in finding solutions within, because the solutions are there. Because again, families are also different. So sometimes patients come with mental illness, and as I talk to the family and the people around the support group, you're able to tailor what you have with what works. Okay? Like this week I had a patient, yesterday, when was it? Today is a few, like 2 days ago, I had a patient who had depression. The support system is very unique because the only support she has is a daughter who is in high school. The others are a bit far from there. So I was planning to have a sitting with the daughter sometime next week because she is the support the mother has. So in that, you can't go involving everybody or something, you know. So I become part of the support. The daughter becomes part of the support. When we come together, we see how best to do that. But the principles are all the same. So we're not really banishing off the Western whatever, because they are good things they have brought to us, definitions and all that. But again, tailoring it. That's what I will say. And you will find a lot of solutions within, like the way we say it. There are traditional healers who, again, you know, people used to find solutions different. Everybody is looking for a solution. We borrow what works because everything is of God. You know, like you look at it, the vegetables we eat is all ours. You see, the knowledge we have is all ours. So I'll piece up, like I've been in a mental class, I've done psychiatry, I've read about psychology, not been in a psychology class. I develop people spiritually, and I borrow all those, whatever works, because you'll find a patient who, like I was saying, is very spiritual, and that has been their coping mechanism. If you find a solution for that person, you literally have to go that way, otherwise you will not have a solution per se. There are people who you send to their pastor, and their pastor will give a better solution than a psychologist will. There's another one who 50% is a psychologist, 20% is a pastor, and you're looking at all those dynamics. And that's why I'm saying I'm not too much into research, but observation is that you integrate all that. There's a place for medication, there's a place for diet, there's a place for physical exercises, there's a place for all these things, but we tailor and see how it works.
Yeah, and maybe just like also an invitation to Dr. Were, and I think I'm coming at this also just from a more kind of different perspective, in that I agree, kind of like broadly within general health, like a lot of the things that we are borrowing actually do really work. But I do think with mental health, my invitation for you is to also, maybe consider this later from, obviously you're the doctor from that medical perspective. From a mental health perspective, actually, my 2 cents is a lot of these assumptions that we've used to build our evidence-based, don't work, right? And so to give a concrete example, with malaria, so malaria has a very specific cause. It's one type of mosquito which has to bite you. Very specific set of symptoms. And then an anti-malaria drug only treats malaria, doesn't treat tuberculosis, etc. But if you think now about mental health problems from this medical thing, all of these assumptions don't work. As you've mentioned, what causes depression can be environmental, can be biological, etc. And even within the same environment, one person may be depressed, the other person is, and same with the symptoms. Medication for depression also works for anxiety, also works for people who have bipolar, same with therapy, right? And so the reason I'm putting this as an invitation is I think, at least for those of us who are working on the research perspective, I think it also, in my opinion, presents us with this unique opportunity to also think about, outside of the more traditional malaria-like, medical model, given that most of these assumptions generally don't hold for mental health. It might be, for example, that depression and anxiety are the same thing, because you find, most people who are depressed are also anxious, right? Yes. Or even if you look at substance abuse and ADHD or conduct problems, most people who are abusing substance also tend to have a very high level of comorbidity, with a lot of mental health problems, right? And so, like, maybe we don't need to think about them as distinct disorders, but I do agree a lot with, this idea of, I think also your point around if someone is coming from a religious, disposition, they will only feel that they are, quote unquote, been cured if they can understand it, from this framework. And that's why, at least in traditionally, we used to have a lot of rituals in most African communities. Like, for example, if someone was mentally ill, they'll maybe be taken to see a healer or etc. And then when they come back, there'd be this like ritual of like acceptance and being brought up into the community. And part of Dr. Ndete's work was actually even making the argument that perhaps part of the therapeutic part of traditional healers and also the clergy is that ritual element whereby, okay, I may see a psychiatrist and they're telling me I'm getting better, a psychologist, they're telling me I'm getting better, but my view of life is really defined from this spiritual element, and so even if it's going to church and giving a testimony that, I was going through this and now I am feeling better, can in itself also really help with like the therapeutic process. So I do like 100% agree on the need to tailor it within different ways in which people are viewing and seeing life.
And to add to that, I think the aspect of research that is relevant in our context is a big area. I know we use that which is available, but if resources and time and what can be veiled so that we have what fits the different areas like where we are now, that will really go a long way. But in the meantime, we keep growing and doing those researches, reading about what is relevant here, and also adapting it to the situations we have as we go along.
Yeah, and that's a great why we're having this
Yeah.
conversation. I think you're working really on, you see clients every day, and so like you have to help the clients feel
Yes.
better, every day, right? I'm coming from perspective where I actually I don't see any clients that
Yeah.
I'm coming from a pure
And
Research and
research and
exactly.
theoretical, perspective, right? And so I think part of the synergy is kind of like the cross, pollination of like
Of both your
ideas
work.
and both
Yeah.
worlds, to advance and move forward. Yeah.
Both are important. And I think from both of you, if there's something I'm hearing a lot is, which I think I'd say Africans are very good at, is task sharing.
Yes.
When I view things from the Western perspective, a lot of emphasis is placed on the professionals. So the psychiatrists, the therapists, the doctors. But if we look at, just in Kenya, for example, there's a lot of task sharing. When you bring in the clergy, for example, you're looking at an ecosystem of help. So, instead of focusing on one particular point, how can we bring in all these people to make something work? But also that calls for what both of you are talking about, creating systems that make sense to us and being able to define things in a manner that makes sense to us. But as we're talking about the sharing of tasks or task shifting, and Tom, I'll ask you this specifically. In Shamiri, you used a task shifting model, right, with the lay providers. And this is a very practical solution to the psychiatrist and psychological shortage in Kenya. But of course, there are some risks like around the quality of care and potential burnout of the people who are doing this job. So in your opinion, what makes it work?
Yeah, I think I'll answer the question and also slightly push back on the premise of the
Please
question.
do.
So I think of task shifting more broadly as amplifying expertise.
Okay.
So it has to start from the perspective of expertise, right? And I think the best example for this actually comes from primary health, where this has been used a lot and it's kind of like really more defined. So if you go to a hospital, the way the hospital is set up is in a task shifted, approach.
True.
Of course, you have a medical doctor, but when you come in, you have a nurse, who takes your, vitals, for example, and you have someone else, kind of like who runs, the lab, right? And then we built on that, and then we started having community health promoters who go in and either get people to get vaccinated or do like kind of like basic kind of like screening, right? So the at least how I think about it, the broader principle is if you were to have, for example, Dr. Were run everything in his clinic, it is impossible for him to do it effectively and also kind of like to meet kind of the need, right? And so the reason why I'm citing that framing is just to push back on kind of like what sometimes is the narrative that you're taking away the expertise of the doctor and you're giving it to the nurse. No, that's not what we are meaning. That's not, at least from our perspective, the ethos of like task shifting. It's like, okay, how do we amplify the expertise of the doctor and of the hospital, kind of like to do it. So when you think about it from the perspective of mental health, and first of all, I do have a big problem with the distinction between psychiatrist and psychologist because it was built, in my opinion, on the wrong assumption that the brain, quote unquote, like the hard neurons and chemicals of our brain is separate from our mind. But I do think there's a lot of kind of closer interconnection around that. But that said, if you now think about, mental health, there are functions, for example, once again, assuming our diagnoses are correct, but assume the diagnoses are correct, you need someone to be able to do that diagnosis. The equivalent in primary health is you will not have the doctor will ask someone to run, kind of like the test, and the doctor will read the interpretation of the test, but most of the time they're not running the test for themselves. So similarly, can you task shift that process of doing the initial intake diagnosis to someone else, within, like the model, right? And then more pertinently for psychology, part of talk therapy are actually, in my opinion, skills which are not in the exclusive domicile of psychologists. For example, like what you're doing here, having a conversation, asking questions, holding space, asking follow-up questions, Actually, one can actually make the argument that there might be people, for example, like the clergy or teachers, even coaches, who are way better at, building interpersonal connection and, personal dynamics to get people just like to talk. But obviously, if someone was suicidal and that person, kind of like needed to get medication for that symptom, that is not, like within the remit, of that person. So with that in mind, kind of how we've implemented, kind of like our task shifting model is just on the realization that there are 4 child and adolescent psychiatrists in Kenya. They're not going to be able to do everything for everyone. There's less than maybe 500 child and adolescent psychologists in the country. They're not going to be able to do, kind of like everything. So you think about the tasks involved within mental health, and you ask yourself, can other people be able to do, kind of like this different task, right? And so our model has 3 layers. So the first layers are lay providers and non-professionals, so high school graduates. And the crux of what we train them is just to like lead group sessions. And in fact, we actually make the argument they may be better at leading group sessions for young people because they're closer in age, they connect to them, they understand like the language, etc. But what they cannot do is if someone has moderately severe symptoms, or if someone, needs one-on-one care, it's beyond, kind of like their remit to do that. And so that's where the second layer comes in, which are folks who have some mental health background, either bachelor's or a diploma, etc. So they can now do a way more formal diagnosis. They can figure out, okay, do we need to refer this person to a psychologist or a psychiatrist? They can also offer oversight, kind of over the first layer. And then eventually the third layer is obviously integrating to the few psychologists and psychiatrists, right? And I think the reason why that is important is I think a lot of the quality questions tend to come from, in my opinion, a misunderstanding of task shifting to be like you're replacing like psychiatrists with right. But just I think the health model helps. Like there are clinical nurses, some of whom are trained enough to even give a prescription, but they're still working under under kind of like a doctor, and that has worked really well within like the primary health space. But then also on the evidence part, we now do have almost 20 years of evidence, not just in Kenya, but in India, in Zambia, Zimbabwe, in fact, they train grandmothers to offer one-on-one therapy, so we do have evidence that, like this is effective. And I think, in my opinion, it does present a really great opportunity. And there's also like a really great parallel, which is the status quo of how care is done in primary health throughout, that involves different people doing different, segmented roles.
That's actually a very comprehensive breakdown, and it makes a lot of sense. Thank you for that pushback. Because when you're breaking it down, I can see it very clearly that, without all of that, it could be that this one person, the psychiatrist or the psychologist, is dealing with all this on their own, which is, it's too much. It's just too much for one person to deal with. But when we have different players involved, and as is necessary, we escalate things, then it's easier for that process to take place. And just like you said, it's actually amplifying, somebody's work. So Yeah, it's brilliant. It's actually brilliant.
Yeah.
And maybe you can speak about that model in primary
Yeah, and
healthcare.
I love that model. If you read the if you read the ancient council, there's a story we were told when we were young of Moses and Jethro. Jethro came and advised Moses. But Moses is out dealing with the issues of the Israelites and he's dealing with every case. So every Israelite is pushing into this one man. And his father-in-law comes and tells him, why don't you appoint guys who can do some of these things for you? And then the hard cases, which they can't solve or are complex, comes to you. And is the same principle. Look at that and I'm a strong believer in that myself, that the more you empower people, because most of the societies, the more you empower people, the more they are able to take care of things. So in my consultation room, I always have 2-3 other seats. As it's not the ordinary consultation room where you have the patient and yourself. I always want to see who is taking care of this patient there. So every time they come with the patient, I educate them. They do the job better than me, for me. And it eases the load on these psychiatrists and counselors, these psychiatric nurses who are few. Because the truth of the matter is with the resources we have and the environment and context in which we find ourselves, the workload is too much. If you just went to the ward alone, right now we are talking about the current surveys that you could find up to even 30% of patients who are on the ward having some form of mental illness. And so even the cleaner in the ward needs to have some capacity to offer some solution. I think it's it's a cultural system in which we've been raised. People are more selfish to defend their territory and all that. But the truth of the matter is, I would like cases that the young clinician I work with can't handle coming to me. Like I am a family physician. We are very few in Western Kenya. I have to go see patients booked in Malaba, in Bungoma, sometimes Eldoret or where. But if I have teams that I've mentored, and the issue for me is pouring myself into my teams every time. It's a principle of life. I pour myself into them so that they are able to solve most of the problems. Like I've left connection, I'm not there. If I have guys working and they reason and do things like me, I'm a happy director, you get. I think it's a shift, and I like this discussion because part of what we need to have as we do primary health is sometimes what we call reverse referrals, where like if we have teams like that in communities or in health centers or some most of those guys trained, then I have sessions where I go to empower them every time I meet them. So what I will be able, like if I came to a psychiatric clinic or mental clinic and you have 80 patients, if I come and most of those are sorted and I only see 5 who need more attention, that would be easier. Otherwise, you will never achieve the goal. It's like a father, if you do not empower your children, then who do you leave the legacy with? You are the psychiatrist, and when you get to an age you can't, who will treat you if you are having Alzheimer's disease and you have psychosis, And I think that's the mindset we need to have, always empowering, always empowering, always empowering. And that system will really work. It's a good system.
Yeah. And actually, when we think about it, I think we have examples of that in so many different sectors. Even if we look at the courts, the way when you have an issue, you don't go straight to the High Court or the Supreme Court. You start somewhere. You can even start with just mediation.
Yeah.
Right? There are people who are trained to do that, or first aid before you end up going to, I don't know, the clinic or whatever. So yeah, that really helps us shift in perspective, and it really helps to appreciate that kind of system. So Dr. Zaccheus, when we're talking about community ecosystems, could you break down what the key actors are in Bungoma, for example, when someone is struggling mentally?
It's a good question, because I think it's the essence why we are here, to identify what we have and the gaps there are. And I was saying, I think where the ecosystem starts is the individual. How much do you understand about mental health? Is it depression, and where can it escalate to, and what are the consequences? What are the signs and symptoms you need to pick? And then from there is like, what can be handled? What is the coping mechanisms you have, adaptive mechanisms that can help? And if it can't go, like let's say you have lost a loved one, most people recoil into the track normally, maybe because they have built themselves beforehand, prepared themselves for circumstances that are extreme, and they are able to handle that. And now you go down to the family level, because you find those people break for long. Maybe their parents or their siblings will be there to handle them and take care of that. And if they have capability, and that's why we were talking about the issue of empowerment. If they have the capability, most of those things even won't go far. Most will be sorted there. And then from there, you go now to a healthcare system. Like let's say now community level, maybe you have those groups or people who do that. Like right now we have the CHVs and that system of primary health. Maybe if these guys are empowered, then you have a good system. But it's something that has been there, but like we were saying, most people were involved in more fighting that system than making it work, because we're trying to solve a problem, you see. And if we looked at it, let's say they are empowered, there's a solution that is found there. And if there's anything complex that can't be sorted, then it's escalated over to health center or somewhere, and most of them are nurses and clinical officers who are there. And are they empowered enough to identify those things? And I would say maybe not, because most of them is more physical disease and all that. And if they have any of those psychiatric issues or mental issues, they rarely take any actions or something, okay? So again, it is talking about the ecosystem there is, and identifying the gaps we have, so that some of these things we are doing are very important. And then from there, most of those mental health cases will be taken to level 4s or level 5s, as in, let's say, that means there are facilities that have a consultant or have someone trained, a clinical officer, like has done maybe a higher diploma in mental health and all that. And then you have huge numbers, coming in with mental illness, and most of the clinic you'll find people are trying to clear the line. And I told you, most of these psychiatric issues, you're dealing with issues, depression or suicide, require time. So that's the ecosystem that is like. And then a few cases which we can't handle at that level, then we send to Eldoret or we send to Nairobi. Or if people are lucky enough, they have some finances, they'll go to personal psychiatrists or counseling centers and all that. But I would say that's essentially what is burning in us, to have a system that is a bit affordable, accessible. So anyone who comes to my hospital, people should be able to identify there's an issue. Are they camped? How are they expressing themselves? Are they sad? So if we trained people from all over levels like that, from the individuals themselves all through to the psychiatrist, we'll have better outcomes. Because by the time you get a person talking about suicide or having ideations of suicide, then you're already sitting on an emergency. My philosophy is you rather prevent, you rather have people seeing that and having very high index of suspicion from the word go, from whatever level. Like if you have peers and you're playing with them or you're talking with them or you're classing with them, they should be able to say Zach has changed. It's something that is not okay. Small things irritate them or something, and they're able to pick some of those things. So that's the ecosystem like we are trying. And I know some of these things will activate a forward push into better results. And also just lobbying into my colleagues or other people in the health system to embrace some of these things, because they are not typical per se, but they are things that work, and they are things that we can promote. Yeah.
Just there's something that you've mentioned more than once now, and I'm curious to know, just like he said, a lot of professionals tend to be they gatekeep, what they have. So if you're bringing a model like yours, it can be very hard for somebody to buy into it. How has it been like for you to actually get psychiatrists and other professionals to buy into such a model?
I think for us, at least in my experience, we're kind of like on the cusp of a really, and it's just my feeling that over the next 20, 30 years, how we are going to be thinking and treating mental health is going to really change. And a lot of that is actually going to be informed by, research from Africa, Asia, Latin America, etc. Because no offense to the West, but we've given them a 300-year head start.
And there's no progress.
They haven't really taken us
anywhere. Yeah.
They've tried,
they've taken us somewhere, but yeah.
But I think moving from 60% now to 90% and 95%, is going to need new type of like thinking, new type of like work. And that's one of the reasons why I'm really excited and inspired by not just the work we're doing at Shamiri, but even like the local universities, Kenyatta University, University of Nairobi, are starting to build out this like, research, centers to, start to think about this. So I've been really energized over the last 5 years that we're starting to see, this momentum. And I think it's going to be very important that we as folks on the research side don't work in a silo, because it's very easy to be in front of a computer and looking at data, and start also like doing more cross collaboration and cross research work with folks like Dr. Were, so that we can make sure that not only like the things we're suggesting are practical, but there's also a lot of like knowledge and hypothesis and data that comes from just the experience of being with a patient every day that we want to be able to capture in the research that we're doing.
Okay, wonderful. Do you want to add anything to that, Dr. Were?
Yeah, just thought, like, I thought about the facilitative role. That means like we're talking about integration, cross-pollination, sharing tasks and all that, and that puts a lot of responsibility on the experts in the area. Like, say, I'm a family physician, so if I am the expert in the area, it means I need, in addition to what I'm trained in about mental health, I need to develop some more skills to develop groups, to to sharpen the other, so that to make that model work. And it's my call inside of this podcast to sound for an open mind, in the sense of, if we're looking for a solution, like Thomas said, that has not come over those years, then it calls for a paradigm shift in how we handle things. So the experiences I have, the experiences the religious leaders have, the experiences that the Asian people have gotten, the experiences we've gotten in the African context that work, all those things are incorporating in the dynamic, and I'm thinking about that facilitative role, especially for the experts. And you can only facilitate if you know it's part of the solution. You're always thinking about team, always thinking about collaborative approach to things, and not one linear way of finding a solution. Yeah.
Okay. So we are now living in a digital age, right? And digital mental health tools are gaining popularity, especially with access and innovation. But we also know that connectivity and ownership of devices is uneven across Kenya. So how realistic would you both say it is to rely on digital mental health tools within the Kenyan context? Tom, may I start with you?
Yeah. So I think about it in two ways. One is now, and second is from in the future. So it is inevitable, especially with Gen Z and Gen Alpha, like it is inevitable, like just the way the world is moving, that most of them are almost going to exclusively use digital devices for mental health. Not everyone, but it is inevitable, like, the cost, like maybe right now it's not the case, but mobile phones are going to become more accessible. Internet is becoming more accessible. The world is becoming more digital. I think that's just an inevitable trend that eventually will be the status quo in most parts of Kenya. And so how I think about this is, with this in mind, how do you build for both today's world and kind of tomorrow's world? And so in today's world, I think the biggest role that digital technologies can play is around improving access. Right? So as Dr. Were mentioned, sadly, most psychiatrists will be in Eldoret or in Nairobi, etc. But digital technologies offers opportunities for like teletherapy, for example. So you don't have to, like call, more immediately. So I think there are logistical and access issues that exist now for which, so rather than think about digital technology as an intervention of it in itself, but how can it improve access to providers and interventions? And I do think generally the technology infrastructure to do that is that the most basic just being mobile phone and telephones, right? But now if you think about the second part, okay, how does this look like in the future? And that's a little bit troubling for a few reasons. So sadly, or non-sadly, I think part of the reason why most people are going to be using digital things, even now with AI, as therapists, is because they just can't access traditional, providers. But that's inevitable now. Like people are starting to use these things, and so then the question is, are digital interventions effective to be used as interventions? And right now the answer is no. Both because we don't have evidence that they work, but also more importantly because we are training them on data which we've kind of agreed doesn't always, kind of like work, right? And so the consequence of that is you just exporting the issues we have currently now, into, like this digital, world, right? And that's why at least our tech and AI strategy at Shamiri is less around thinking of digital technologies. And then the second part is, we think like these digital technologies and AI can also help us with, kind of like what Dr. Were was mentioning earlier, which is figuring out how to customize things to the individual, kind of needs, right? So you can become much better at, building profiles and realizing, okay, if this is a 12 to 14-year-old female from this type of background, etc., this approach will maybe work better for them, kind of like at this approach, right? So at like personalizing care. And hopefully in personalizing care, we reach, kind of like better outcomes. The moonshot idea, which most likely will not happen, is maybe AI can do a better job at helping us understand why mental health treatments work. So I think one of the reasons why we've failed to increase the efficacy of mental health problems is we don't really have a full or a clear understanding of the mechanisms of change. So if I give you this antidepressant, we do have some theories, but most of those theories have been debunked, right? Whereas, for example, if I give you medication for COVID, for example, assuming we had one, I will know that it works by targeting this very specific, virus, etc., like how it does that, and we know that that's how it works. So we don't really know that for both psychiatric medication, but most importantly for like psychological interventions. So if someone is depressed and they're going through therapy, how is the therapy leading to, changes and reduction in depression? So in theory, if we can understand these mechanisms of change, in theory, we could then build more potent interventions, that could lead, like to better outcome. Yeah, so that's my thinking on this.
Okay. Dr. Were, in Bungoma, I know there's a huge digital gap, right? Whether it's access to the devices or access to connectivity. What would you say about the role of these devices and this connectivity on the ground?
It's interesting. So IT technology, it has its own advantages, as you've said. These issues of advocacy, education, mobilizing all that information, which is very key and important. The other aspect is it also carries within it the very risks of, because there's social media pressure, which right now is sending a lot of young people into mental illness. Surveys being done now in campuses, in colleges, you're finding a lot of young people with symptoms of depression and anxiety. Most of it pushed by the pressure of social media. And so it poses a big opportunity for reaching out and information and solutions, as we say, but also a big danger. And that calls again for how do we train these young people and ourselves how to better use the digital platforms we have, the environment in which we are in. Most people are spending almost all their time on the phone. Their product and not really maybe watching or developing themselves, and then I will talk from experience. I am an employer. The most young people you get are like can't give results because they spend most of the times on social media, wrong spaces, and also media spaces give them pressure. and they are not. You can use social media for skills and for all that to better your system, because the ones who do come out very well. But also again, the way I was saying, the pressure of the looks, the what you need to have, what others have, where it's like so the caution again around there, and it poses a big opportunity, but again for parents, for teachers, for everyone, for this generation, it's just questions: what should we do? You see. And then the other aspect you brought up about the possibility of finding solutions we have never been able to, or answering some questions. It's interesting because the world is getting very complex and the solutions look very hidden. We know too much, but the more we know, the more we get confused, especially on aspects of mental health, because mental health is deep, is wide. It has a psychological aspect to it, sometimes physical aspect, sometimes spiritual depths that are beyond. And I look at where AI is going, gives us more information, but the more we get into it, the more the complex matrix happens. And for me, like a doctor, I'm beginning to see patients who come knowing a lot, which is good. But then what I have found works is the ability to know how to piece up all that. You see, like so there's all this information and all that, which AI can't do. Is sorting these complex issues. How do you merge up someone's psychological, mental, spiritual, financial issues? So someone comes to me and is seated there, I have to tell the reason they got into mental illness is because they are broke, you know. And I use the AI, which will give me the solutions, the information I need. Like if you type, how do you help a mentally ill person that came because of some financial problems, because of their business did this? So it will give me a list of all those things that I need to use. But then which one do I start with and which one don't I? And it's like that's where AI might not give the information. That only means that the expert in the mental health area needs to be more complex. But the solution you give is supposed to be very simple because it has to work. You get all that. And so it's an opportunity, it's a big opportunity that is coming, because now information dissemination becomes easy. It's easy to go to schools and send videos or something for people to watch. Like right now, there's a university student I was treating depression last week, but one. And she's schooling in University of Nairobi. I'm in Bungoma. I'm able to do that because we can do video conferences with the mother and themselves, and the other side. So you can do Zoom meetings. You can do which are low-lying fruits of digital technology and all these things. Which and for me, it's a good discussion for us to start talking, but send also a warning sign a warning shot to all of us that it's still a big risk area that is yet to be studied. Yeah.
Yeah, 100%. I agree, and I think to your point, I agree. Like there are low hanging fruits, like Zoom, teletherapy, etc. And then obviously, kind of to your point about if you're a provider and you're using an AI to it's giving you, kind of like these things. I do agree. It presents both the risk of is the information that it's giving you reliable, and then second, how can you do it and implement it within your context, right? And that's why I was saying I do think the initial possibility with AI is almost being as a thought partner,
Yes.
right?
Yeah.
But still, kind of like emphasizing, the expertise of the provider. On the risk factor, I hear you. I think the place where I am sometimes, kind of like stuck is, like social media, for example, has been an emerging risk factor over the last 10, 15 years. But now we've also got into a point where it's almost the general way of life,
Yes.
for
True.
young people that, we kind of almost don't have the ability to just be like, okay, we are not going to be in social media, kind of anymore, right? And so then the question for me there, which I don't have an answer to, is how do we both mitigate the dangerous and risky, kind of like parts of it? But then how also do we deploy preventative and therapeutic interventions in a social media or in a digital, age world? But also just to defend young people. I think every generation normally always thinks the younger generation can't deliver. Even when I think you're young, I'm sure
Someone said
these young people.
True.
But that was just on a light note.
True. What I like about what both of you have spoken about is, as you're speaking about the digital tools we have, I think what is most common is either completely to shut it down or now over reliance on the digital tools. But I like the acknowledgement that, this can help, but also these are the risks. And then the curiosity of like, okay, what more can we do? How can we make this useful to us since it's here? We can't act as if it's not here. It is here. What are we going to do now to make it more useful to us? So let's shift gears a bit. You've both been working in the public and mental health. What shifts have you seen that give you hope in your work? Maybe Dr. Zaccheus, I'll start with you.
Yeah, there's there's hope. There's hope, and that hope has to keep increasing. Because I think without the hope, then people get into more mental illness. There's a lot of hope because now I would say the stigma is being destigmatized. The knowledge is out there, and that continues to go so. And I think even the expertise, I would say there's more development. There are more people going into training. People are accepting that roles and all that. And even the community support and all that. You see, it's from the time I started practicing in 2013, I've seen a shift in how even parents take care of things, how the families support mental health patients. So there's good hope, and also the fact that we are also doing this having this initiative, it tells me that there's mobilization that will happen. There's people still starting to think about mental health. I've seen a number of my friends, even on Facebook or social media, talking about mental health, and some of our advocates of mental health and not necessarily experts. You see people advocating for that, and there's hope. And we can't give up hope. It's all we have. It's good to see, us, we young people, like you're saying, sitting here and promoting this. I know if it goes out, there's some impact. It's something I was thinking in the morning before I came for this podcast. I was saying, we might not go into the details of everything, but let what we say go out as a ripple. If anyone listens to us, it goes out as something that, what do I do? What's my contribution to this? Now that I'm mentally stable, what do I do to contribute to someone who is not stable? And the fact that I'm resilient in this area, how do I train the other person to also be resilient in that area? I lost a job, but I stood my ground. I woke up, I did this. Can you start something to educate the others about how do you stand when things don't work out? So there's hope, and that hope has to be clamored. Yeah.
No, 100%. And I think part of the work that we do, those of us working in this space, is to cultivate hope, right? For Dr. Were, like when he works with his patients and etc., I think a huge part of it is, just building, resilience and hope that they can get better, right? And also from my perspective, not just with the work we're doing at Shamiri, but more from like a system level perspective, having the hope that, we can push, the field, forward. But more concretely, I think, as I mentioned earlier, Kenya, in my experience over the last 5 years, because that's, I've just been doing this since 2021, I think there's been a lot of really significant improvements that have started to lay down the foundation for what I think will be maybe the golden age of mental health in this space, So, for example, the Mental Health Act of 2021, it was a small thing, but we didn't have any formal mental health act, since the colonial, era, right? So that was, kind of one big thing. I think the policy now, it's not yet implemented, but policy which tries to integrate mental health coverage within universal, health coverage. So the formal policy position of the government of Kenya puts mental health in the same right as other, kind of like health issues, which is, also, another thing, which is happening. And these are small things now, but they begin, for example, to create the space for, organizations like Shamiri, for example, to be able to work in, to be able to build infrastructure, advocate for things. Second, we're also starting to see a lot of new knowledge being generated, like locally. I think now we have at least between 50 to 100 new peer-reviewed papers coming from Kenya and Kenyan scientists and researchers every year. So we're starting to build our own, local knowledge, which I think, kind of is pretty, crucial. But also most importantly for me is the demographics of Kenya are set in a way that mental health will have to be prioritized because, as Dr. Were has been saying, for some reason, young people have decided that this is going to be a priority, conversation for them. And of course, it's different across the country, but on average, even in rural communities, younger people in rural communities are more willing to talk about mental health than, for example, their parents, right? And so I just think because of the nature of the demographic, it's just going to be inevitable that we need to make progress to meet the needs, for this and the demands for this. And this is what leading to what Dr. is saying, that you're seeing more people going to school now to learn this, more people doing this advocacy. You're doing this podcast as well, so I think that's giving us hope as well.
Okay. So one last message from each of you to wrap up the episode. Tom, let me start with you. Final message.
So my final message is an invitation to everyone to challenge how they think about mental health. I don't have an answer or like a framework for I think we should think about how we should think about mental health, but I think how we traditionally think about it, maybe not what is going to, like lead us to the next space. And in the process of challenging how we think about mental health, I think it will present a lot of opportunities and possibilities for us to, close the treatment gap and build a system, for Africans by Africans and that work for us.
Great.
Yeah.
And you, Dr. Were?
Yeah, on the same line, I think mine is like a broadcast into the heart of everyone that let's be a sanctuary. Let's be a home. I think with the increasing troubles and crises around the world, the hearts of the people are crying for a sanctuary, a home. And if you can build your own resilience and capacity to stand above the chaos, then you automatically become a sanctuary. And if anyone and every one of us can build their hearts and their lives as a home, so you can house someone else, guiding them, leading them, training them into resilience, then that's it. If this podcast, all these efforts we have in building whatever we are is to build a home for people, then that's it. So I'm calling for everyone to be a home for someone else.
Thank you both. You've brought such powerful and insightful points, and you're both doing amazing work. So I'm very honored that you accepted our invitation and you came to have this conversation with me. So
Yeah,
thank
thanks
you.
for having us.
Thank you. It's a wrap.
Finally.
Hey, thank you for your patience. We have come to the end of the series, and we began this series by asking questions. What is working? What is not working? Where can we do better? Where can we ask more questions? How can we help more? How can we understand more? And we have also wrapped up asking some more questions, trying to understand what really has been working. What can we challenge? What can we push back? Can we look at things in a different way? Stop adapting the Western perspective, but create a model that works for us Africans. Like I said in one of the previous episodes, we may not have the answers or all the answers, but asking questions is a really good place to start. So I hope that throughout this series, you have managed to stay open and curious, willing to learn, willing to question, and that hopefully throughout the series, you've developed a little bit more compassion, a little bit more understanding, and a willingness to learn something new, a willingness to understand what maybe you did not understand before. Thank you for joining us thus far, and we'll see you next time.